Now it's a presentation. All right, types of clefts. So we have different types of clefts. We got to get the right angle. Okay. Okay. So we have unilateral cleft lip and palate, bilateral cleft lip and palate. Clefts happen early in gestation in utero. There's no real reason. We don't know the reason. Sometimes it's genetic, sometimes it just happens. And a lot of moms will want to know, why did this happen? What did I do? You didn't do anything. It just kind of happened. You can have a cleft lip without a palate. You can have a cleft palate without a cleft lip. You can have a one-sided cleft lip and palate. You can have a bilateral cleft lip and palate. What we do know is if you have cleft lip and palate, a lot of times those just kind of happen. There's no real reason for them. Sometimes they're tied with a genetic syndrome. But if you ever see just a cleft palate, those are more syndromic, which you would think it'd be the other way around, but it's not. And then you can also have a submucosal cleft palate, which are the hidden ones that we don't find till later, where the muscles really don't suture together, but the mucosa is intact, so you don't find those till later. And they only give us trouble about 30% of the time. Some of these are, you can see them and then they've been repaired. Click over. So he's one I'm going to talk about a little later on. I love this little kiddo, but they come in all different shapes and sizes. His is a unilateral, it's very wide. It almost looks like a bilateral, but he's been repaired recently. If you'll click again.
Look at the end, he looks so good.
He looks great. So if you'll click on play, Susie, our nurse practitioner, made these morph, and I think they're amazing. They just look so good. We repaired him recently.
It's amazing to see it.
Yeah, you can barely see it, yeah. And then on the next slide, we have one more. Oh, hers is really wide. It's a unilateral. You can see the premaxilla popping out underneath. She came in for a cleft team visit. I didn't even know who she was. She just came in recently. She's almost 2 now. Amazing kiddo. Go ahead and click to the next slide so I can remember what it is. Sometimes you have cleft of the secondary palate. Okay, so sometimes it's the whole palate, and a lot of times the doctors or the nurses will put a glove finger and palpate, and you can feel like an opening. If it's back in the soft palate region, you're not going to feel it. So the hard palate, just real quick, riff in the mouth, you can feel it. That's what I actually tell my families to do. Then run your tongue back like you're going to gag yourself on the top. It starts to get soft. That's the beginning of the soft palate. Can't see your soft palate. It kind of goes up in there and it hangs down in the back, and your uvula is the tip of it. And then you have the back of the throat, and when you're talking, it kind of raises like a little knee, and it seals with the posterior pharyngeal wall and lateral pharyngeal wall like a valve, and it opens. And it's to keep all of that sound and airflow in the mouth for speech, and it does help with swallowing too. But big thing, and I've been told to tell everyone, please use a light when looking in their mouth, because you cannot palpate and feel a cleft in the soft palate. It can cause, depending on how big it is, it can cause feeding difficulties. And so we'd actually had a couple of these come in lately. They were just not found. And finally, after weeks, you know, these babies eat every 2 hours, and now they're losing weight. They don't have good suction in the mouth because there's an opening in the very back that we haven't found. No one's found yet. Finally, we found it, and then we can adapt their bottles, and then they can grow. But always just use a light. We even have to use a light. We always use a light. So anyway, that's that one. We are approved with the American Cleft Palate Association. We're the oldest approved cleft palate team in Orlando. Because of that, we do have a lot of multidisciplinary team members that help us out, and we do have an annual clinic. Actually, it's twice a month, but all of our patients filter through like once a year. We have, of course, our surgery, orthodontics, genetics, speeches, ENT, audiology, social work, and we work together because these kids need all of us. If a cleft is in the middle of a syndrome, well, we definitely need genetics to figure out, do we need to send them to cardiology, ophthalmology, you know, what do we have learning difficulties, all these things. Hearing is sometimes impacted. They're going to need orthodontics to move their teeth around before we can do some of their stage surgeries throughout their life. So we need all of them to help us get these kids through the surgeries that they need. So we're going to talk a little bit about the feeding problems caused by cleft lip and palate. So because babies having cleft lip and palate can have feeding problems, we have a feed and grow team with us, which doesn't help you all over here, but I'll talk about what things that you all can do. But we developed one over there. What was happening before is that these patients were going in, they have cleft lip and palate, they see Susie, our nurse practitioner, and our doctors. They're having feeding problems, so they send the baby over to outpatient rehab, which is where I was. And then we would change the bottle, we'd change the nipple, we'd show positioning. Well, what if they're having reflux? What if there's digestion problems? Well, that's out of my scope of practice. So now I gotta call GI. Now I gotta get them in with GI. So now you gotta make an appointment. You gotta get them in over there. It takes time. Babies eat every 2 hours. Failure to thrive happens super fast. So we got a great idea. Why aren't we doing this together? So we started meeting together over there. Now we have speech pathology housed within the surgery practice. So we're there all the time. But our GI people come over. That's me, Kathleen's the other speech pathologist, Susie, our nurse practitioner, Geronda, our nursing coordinator. This is Leah, she's from GI, she's our dietitian, and Carolina is our nurse practitioner from GI. So they come over and we assess these babies all at once. So babies born at Winnie, usually, we grab them from Winnie. They're born at Winnie, we have a speech pathologist go over there, they assess the baby, they get them on the right bottle, they teach them how to feed, they're discharged. Within a few days, they come straight to us at Feed and Grow. We make sure their weight is where they should be because we're a surgical practice. We're trying to get them to lip repair and palate repair. First, we want to make sure the baby's healthy because we care about people, but we are trying to get them to their surgeries, so they have to be healthy. If other things are involved, we have to work with the other doctors. So we want to make sure their weight is okay. They're not failure to thrive. We give the parent everything they need to feel secure. We usually see them about once a week in the beginning. We're still seeing Ural's baby once a week. We're getting ready to push him to every other week. And we follow them through their surgeries. If a baby is born with just a cleft lip, or even a cleft lip and a cleft in the alveolus right here, typically won't cause a feeding problem. They can breastfeed, bottle feed with anything. If it's a super wide cleft in the jaw, which I just saw one the other day, if it's super wide, they can't, sometimes they'll lose the suction in their mouth because they got to generate that negative pressure in their mouth to suction. We'll adapt the bottle, but 99% of the time, these babies can feed just like everybody else. The breast tissue fills up the cleft. It's really not a big problem. Cleft lip and palate, or just cleft palate, significant feeding problems. They cannot breastfeed. As much as we would love to have them breastfeed, I do have them, because they still have a suckle reflex. Mom wants to use her breast milk, put the baby to the breast, get that bonding. There's beautiful things that happen there, but the baby's not gonna get enough nutrition, so we have to use some kind of adapted bottle system. A lot of people will say, okay, I'm feeding the baby, the milk's coming through the nose. Yep, you're gonna see the milk. Wait till they're older and carrots come through the nose. It's normal. We have an opening, we have open communication between the oral and nasal cavities, so milk is gonna go up through there. It's the baby's normal anatomy. It doesn't hurt them. They learn to sneeze it on you really fast. We do have our parents feed in a mostly upright position. It doesn't stop it, but gravity will pull it down. But think about it, you hold your baby back like we want to do, and the milk just fills up the nasal cavity. So what we really try to do is feed them as upright as possible. Also, our kids sound a little more congested when they're feeding, and they'll come in a lot of times, are they sick? The mouth and the oral cavity, the oral nasal cavity are open, so that mucus just kind of goes where it wants. They're not sick unless, they typically have viral symptoms, but that mucus just kind of goes where it wants. It doesn't go down the back of the throat, so they sound congested. So that's another thing you might see. But these kids do require adaptive bottle systems. So let's go to the next slide. Yeah, go to the next one. All right. I have no financial kickback for anything, but I love this bottle. 99% of our babies use this bottle. It's just nice. It's normal Dr. Round bottle, And what we talk about this blue, and I'll pass this around, the blue disc or blue valve in the nipple, it's not this. This helps with reflux. It pushes, you know, the extra air down. This blue disc is what we love so much. It actually takes the need for sucking out of the equation, which our babies can't generate suction. That's why they need an adaptive bottle. It's a valve that lets the milk into the nipple. All the baby has to do is strip with their tongue and out comes the milk. They don't need a great seal with their lips around it because they're not going to get one, especially if they have lip issues, you know, or bilateral lip. They really can't get their lips around it. They really just need their tongue. Why do I like this? Because the baby needs to develop their own suck, swallow, breathe pattern. They need their own oral motor system to develop. In the past, when we talk about this one that has been around forever, it's adult led, and I'll talk to you about that in a second. But this is the one that we like the most. It also looks normal. We have craniofacial differences, and a lot of parents are nervous and scared about that, and they're taking their kid out into the community. There's already a social thing happening. Let's give them a bottle that looks okay too. And you can feed with this bottle. Grandma can feed with the bottle. Dad, the neighbor, friends. There's nothing special except this blue disc. Everybody can feed with this bottle. Other bottles, you have to be trained on the bottle. So that's a little different. But this is the one with the blue disc. This is the one that we like. I'll pass that around. It's a sample. It'll fit into any Dr. Brown bottle. So you can get the Dr. Brown bottles and just get the discs and stick them up in there, or of course they're going to sell you the whole kit as a cleft palate adaptive bottle system. But it's great.
So the disc can be purchased individually?
So, okay, so if you call the Dr. Brown, if you get a hold of the Dr. Brown, there's an 800 number on there. They will send you some blue discs. They have done that to our families. I try to give them, but you can't just buy the discs, which is kind of sad. But they will sell you the whole system, right? They'll sell you the bottles with it in there. But that's really all it is the blue disc that's up in there. I have had families say, well, I'll use the regular Dr. Brown and I'll poke a hole up in the nipple some more. Well, then you got a free-flowing bottle. I've seen that multiple times. So now we're drowning the baby. You know, they can't develop their own suck, swallow, breathe pattern. Oh, thank you. This is a pigeon nipple. I don't see this much anymore. It was around for a long time. It's the same kind of concept as that. It'll fit onto any standard bottle, and that white disc fits up into the nipple, and it's a little wider. But it's really for babies 6 weeks and older, and those first 6 weeks are the ones where they have the most trouble learning how to feed. So we don't use it, but you might see it. This is the one that's been around for a really long time, and when I went through school, this is all we had. This is a Haberman. It's an adult-led feeding system, meaning that the adult actually squeezes the milk into the baby's mouth as the child's trying to suckle. That's really hard. Trying to pair that up with what you think the infant can do, and if you've ever tried to feed a newborn, which most of us have, but their suck, swallow, breathe isn't very rhythmical at first. It's disorganized. So it causes some stress with the babies. It's got 3 flow rates on it, but I still use it. It's something that we do use. It looks different. There's no lid, and it will leak in your diaper bag. It's the only downside to it. It's what we had for a very long time. We were very grateful to have it. But if mom gets trained on it and dad gets trained on it, grandma's nervous about using it. The neighbors are nervous about using it. So then they're stuck feeding the baby all the time. You don't get a break. So that's the only real downsides to this. Most hospitals now have the Dr. Brown adaptive bottle. Those are the ones that we within Arnold Palmer use in Winnie. So if for some reason you get one of these, always go to the other one first. It's a little easier and the baby can adapt to it fairly well. 99% of our babies use the other one. I am using this one on a couple right now. You can pass them. You can't buy it in a store, you have to order it. Oh, I'm sorry. Don't you just hit the Aaron?
No, I did. Yeah, I didn't know if you wanted to. Go ahead.
Other methods of feeding, syringe. I have had some babies come from other hospitals, other states, and they're on syringe feedings. Not really necessary. They can develop a suckle. They can eat just like everybody else. That's just, the parents were really nervous. They started syringing the baby and it just kind of stuck. I don't really see open cup. Open cup I do use later on when we're transitioning before palate repair. Just as a side note, our docs like to have them off of a bottle before palate repair at a year. They don't want them sucking because the nipple will go up towards those suture lines. We don't want them to come apart in any way. That palate surgery is super delicate for 4 weeks, and then after that, it's really nice and healed. So we do get them onto a free-flowing sipper cup. And the parent has to, you know, they're in control of giving the child some sips. But I really don't see them coming in as infants with open cups. Just super fast. I'm not going to go through a whole case study, but this is Jackson because it's got him feeding on both of the bottles. Love this kiddo. He was born at Winnie. We met him prenatally. Really wide right-sided unilateral cleft lip and palate. Super family. He was born on a weekend where none of us could get to him, even our cleft SLP Monday through Friday. So they did try him on a Dr. Brown bottle when he was desatting. So he ended up with an OG tube. And what we know, if the baby isn't using his oral motor suckle, you will start to lose it really fast. So on Monday, therapy came in and we're trying to work with him on suckling, so disorganized, really desatting again. Couldn't get his own suckle pattern going. So the Dr. Brown bottle wasn't something that he could go home on. They did pull out the Haberman. And so the adult was doing the suckle pattern so he could learn how to grab onto that. So the OG tube was removed, he went home on a Haberman. Now, remember, we tell you that we gotta feed the babies as upright as possible, which is kind of awkward. They're floppy and they're little and you're trying to hold them upright and you try to get the boppy. It's hard enough, you know, any baby that age. But now we gotta hold them up as upright as possible and feed with the Haberman, so you're trying to squeeze it into the child's mouth. I mean, it's a juggling act. So they come into the office, they finally got discharged, they came in to see me, and just a quick little video if it'll play. Go ahead. Oh, that's just his growth chart. His weight was really bad. He did not like this Haberman. It took him an hour to feed a couple ounces. Mom was getting stressed out feeding him. She was nervous. He was feeding off of her nervousness. I mean, the whole thing was falling apart. His weight was going down. So we had to work with him, but he's doing better now. So this is Jackson, and this is the Haberman. He does have some lip and nasal taping, which I'll tell you. Wait, that's the Dr. Brown. Go back. There we go. So this is Jackson. Mom's sitting on the exam table because we have no great feeder seat in there. But he's hungry. He's going to go to town on it. Mom's going to squeeze it. He's hungry. He's going to get real mad at her in a minute, and just all he does is push back. He cries through the entire feeding, and it takes an hour because she just can't get the right pattern for him. It's just coming in too fast, and it's a mess. And we did find that he was getting some reflux at the stage, so no, which again, some more arching. But it's just really hard to find the right pattern for it. He gets it for a second, and then he's like, I'm not having any more of it. Feeding was terrible. She called us almost every day, which is fine. We want them to call us. So really fast before we started, you'll see some lip taping and nasal hook. We do that with some of our really wide clefts. They don't have to do it, but we think it's beneficial in pulling the soft tissue together while we're waiting on surgery. And the little nasal hook is just to pull this up because it's smashed in because there's no floor of the nasal cavity. It's just to pull it up slightly. You think of these as the McDonald's arches. They're not really circles. And it's just to help pull it up slightly while we're waiting on surgery. If it stresses the family out, they don't have to do it. It's not a requirement for us, but we do think it's a little bit beneficial. So Jackson did do it. And it does bring his lips together a little more for feeding. I think it helps a little bit with that. But anyway, this was the Dr. Brown. We finally got him on the Dr. Brown, so now he's in charge of his own suck, swallow, breathe. Mom's more comfortable with positioning, and he's more calm. He's more quiet. He's not gulping as much. His oral motor's developing. Feeds are like 15 minutes or less. It's just a little better. He's happier. He'll take his own little breaks. Mom's learning his cues better, and she'll pace him a little bit when he gets too fast. I mean, it's just a happy feeding. It's so much better than what it was. We don't have to go through the whole thing because that's basically him feeding. So basically, these are the two takeaway. The two main feeding systems you'll probably see in the hospital, the Dr. Brown Adaptive and the Haberman. If you have a choice, try to go to this one. It's easy. It's just simple. If you have to use this one, absolutely go for it. But know that we're going to try to get them onto this. Any questions about this so far? No?
Lisa, you have questions? No?
Oh, okay. Really fast, just what else we do over there, just in case anybody was just dying to know. Speech pathology, this is for speech. We are integrated in our feed and growth system. We do a velopharyngeal dysfunction clinic, which is we make sure around 4 to 5 years old that all of our kids with repaired cleft lip and palates, that their soft palate is working, because that really impacts your speech development, and that's when we'll probably do another palatal revision for speech purposes. So we have a whole assessment that speech does. We even do nasendoscopy, video fluoroscopy to look at the palate during speech tasks. So we have a clinic for that. The speech pathologist will do pre and post jaw surgery, resonance, oral motor biting, chewing, and speech evaluations for a lot of our older patients. We do short intensive episodes of care of speech therapy pre-op for a lot of our patients to see if can surgery be avoided, because as much as our surgeons love to do surgery, they don't want to unless they really need to. And then we will see our patients post-surgery to make sure that the surgery that we wanted to have had good outcomes. And then we make a plan of care and give it to the community, the school, the private SLPs in the community. So basically within the cleft lip and palate program, our surgeons are fixing the structure, but all the function based around that is speech and feeding. So they fix all the structures, we fix all the functions. So we make a really good team, and I love my job. I love being there. It's a dream job, and I'm so blessed. And that's basically it for right now, because speech is a whole separate thing, and I won't make y'all listen to it.
Perfect, thank you.